Welcome to the Heart.org. My name is Professor Tony Gershlick. I'm here in Munich at the ESC 2012, and the Heart.org session is about looking at the late-breaking trials and hotline sessions. And I'm lucky to be joined today by Wolfgang Schillinger and Francesco Maisano. Wolfgang's from Germany, and Francesco is from Italy. And they've been involved in a trial on MitraClip. And MitraClip has had a checkered past. It's not quite tabby, it hasn't taken off like tabby. There were some issues about the Everest 2 data. And you've done a study that will tell us a bit more about the use of MitraClip in the general population, a registry type study. So would you like to just tell us a little bit background and why you started the trial, and a little bit about the study? Perhaps you could start, Wolfgang.
Yeah, thank you very much. So the Access Europe trial we are talking about today is an observational study in Europe, and one important point is that it is a real-world cohort that is investigated. So we investigate the benefit of the MitraClip system in a commercial setting. So as you know, the Everest trials have been performed in a non-commercial setting, so these were highly selected patients under controlled conditions, whereas what we report today is a commercial setting, it's real world. And what we see in this trial is that the current use of MitraClip involves other patients than have recently reported from. So the patients in Access Europe were older than in the randomized controlled trial of the Everest 2, and they were also sicker. So they had more comorbidities and also a high surgical risk.
Okay, so roll back a bit. Just tell us a bit about how many patients, how they were selected, and what the results were.
So the Access Europe trial enrolled 567 patients in 14 European centers, 4 different countries: Denmark, Switzerland, Italy, and Germany. There were no predefined inclusion or exclusion criteria, so the decision to treat a patient and to enroll in the registry was done by the treating physician. And the only inclusion criterion was the informed consent of the patient. So it was supposed to be an all-comer study, really giving a picture of which kind of patients have been treated in Europe.
And were they patients who had been surgical turndowns, or patients who the physician had decided should have the MitraClip?
Well, that was left to the policy of the individual centers. In many centers, we had a kind of heart team discussion, but this really was left to the institutional practice and was not part of the protocol or part of the inclusion criteria.
Okay, Francesco, tell us a little bit about the results, so perhaps about the demographics of the patient, what the age range was, the degree of pathology, severity, and perhaps give us an insight into the outcomes.
The main messages that we can take from this data is that the real-world population is different. As Wolfgang told you, they're older than in the Everest. The average age is about 74 years.
This is your population?
Yes,
average age
in the axis, 74. And they were patients with multiple comorbidities. Most of the patients, almost 80% of patients, had functional MR, as compared to the Everest, where most patients were in the genital MR. Okay. And this is reflecting the case mix, which is mainly composed of patients who have been selected because of high risk of inoperable. And what is interesting from this data is that although the risk profile is higher, the safety of this procedure remains good. There has been a pretty low hospital mortality, very high success rate of implantation. Almost 99% of patients have been implanted during this trial, although many patients had complex anatomy and characteristics beyond the typical Everest criteria. So there has been learning curve. We learned from the previous studies. The current practice in Europe is improving, and the outcomes are also pretty good.
So tell us very briefly the primary endpoint, at what time, what were the results?
At 1 year, we can tell that 80% of patients have a clinical benefit, both in terms of reduction of MR and in terms of improvement of NYHA class. And also the clinical improvement has been documented by more objective methods like 6-minute walk testing, which increased significantly, and also in terms of improvement in quality of life measured by Minnesota Living with Heart Failure questionnaire.
So what you'd say is, in an unselected group of patients with MR who perhaps may or may not be surgical turndowns, that use of MitraClip seems to provide benefit, albeit that it's a registry and that there's no control there. Did you have any historical controls in propensity analysis to compare with patients who didn't have MitraClip?
Well, this was not in the design of the study. The study was just designed to be a snapshot of the current practice in Europe. There is no comparator group. We're working now on using this data set and compare the outcomes to some historical data from, for instance, the Italian heart failure database. We are going to do some comparisons using propensity match analysis or something to have a good outcome, good data to support our decisions.
So that's fascinating. So Wolfgang, we have to finish because we want to keep it brief. Everyone now will want to go out and use MitraClip in their patients who are elderly with mitral regurgitation. What are the caveats? What are the learning curves? How many should people be doing? What are the restrictions that you would want applied before everyone takes this data and runs with it?
Yeah. Well, we have to be very cautious with the conclusions from this trial. For sure, it's not a therapy that is appropriate for every patient with mitral regurgitation, and it's a complex technique which involves echocardiography in the cath lab, which is not available at every place. So I think it should be regarded as a complementary technique to surgery, and we have to select our patients for this technology, and we have to discuss indications with our surgeons. The learning curve is long, and I would say you need about 25 or more patients until you have passed a major part of this learning curve.
Okay, so I think that's very interesting. I think we'll bring it to a close, but I think the important messages are that this adds to the Everest data in that it's real world, it's patients with comorbidities, and there seem to be good results, but the caveats are that it's a registry. We don't know how these patients may have done without the MitraClip, and as Wolfgang, you've clearly pointed out, no one should rush out and buy MitraClips until we understand a little bit more about the natural pathology, a little bit more about the longer term downsides, and perhaps more importantly, it's good to be an expert because those are the people who get the best results. Would you agree?
I would absolutely agree. So many people believe that that MitraClip has turned out to be a heart failure treatment, and as you will know, we have a statement with some kind of a soft recommendation of this treatment for heart failure patients. But still, it is necessary that we wait for the results of randomized controlled trials, which have been designed and which will start in several months.
Okay, well that's really interesting, and we look forward to further data, randomized trials from both of you, and thank you very much indeed for both collecting the data and for coming along to discuss it with me today. Thank you very much.
You're welcome.